Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm here with Ellie Abel, who is a fourth-year medical student at Albany Medical College, and we will be interviewing today Dr. Erica Bliss, a family physician in Seattle, and she will be sharing with us a story about a major innovation which really showcased the power of family medicine. Dr. Bliss, thank you for joining with us.
Happy to be here.
So, Allie, would you like to take it away?
Sure thing. Hi, Dr. Bliss. So we are asking all of our Bright Spot family medicine leaders to tell us a little bit of background about themselves. So could you tell us maybe where you're from and what inspired you to become a family physician?
Absolutely. So I am a West Coast person. I grew up in California and did a whole bunch of things before I ended up in medicine. But when I was eventually decided to become a physician, my motivation was really to work with communities to try to really focus on broad-based improvement in health. And I was really attracted to family medicine because of the focus on sort of comprehensive care of families, individuals within the context of their families and communities. And I just loved that because there was really this awareness of the fact that we don't live in isolation and we aren't just a collection of organs. We are, comprehensive beings that operate within context always. And I also really liked the linkage to public health and environmental concerns in terms of the awareness of economic, sociopolitical, et cetera, impacts on our lives. I had come from a background in studying history and other social sciences, and so it really appealed to me that this was a specialty that took those kinds of things into consideration in a big way. I think all of medicine does take those things into consideration, but it's really part of the foundation of the specialty.
So then what brought you to medical school? How did you find yourself in medical school after having a background in history and social sciences?
It's kind of a convoluted story, but the real crux of it for me was I was working on a project with an organization in Mexico that was fighting domestic violence issues, and their approach was very broad in terms of looking at the whole problem from a political, economic, legal, and medical, social perspective, all those different perspectives. And it was such an impressive group of women working on the problem. And so for my master's thesis in Latin American Studies, I interviewed all the women involved. And I, for some reason, just found myself very drawn to these two doctors with the group. And the way that they talked about their work and the way that they established rapport with these women just really appealed to me. And I literally had never thought about the idea of being a doctor. So the health component of what they were doing and the way that they were using healthcare as a way of accessing these women's and these communities' lives to help them improve overall their communities was very appealing to me. And so I started just asking some questions. And when I came back to the US, I started talking to different people. And thankfully, I had a lot of great mentors who said, hey, you should really consider a career in medicine, something I hadn't really thought of before. So one thing led to another, and next thing I knew, I was taking my pre-med courses and taking the MCAT, and I was very, very fortunate to get into med school and went to UCSD after that and kept going. And then I came up to Seattle for residency and went to Swedish Family Medicine and was able to land at the public health clinic as my continuity clinic, which was great. So I really got to work with a very diverse population there and learn a lot. It was a wonderful residency program and really got to continue in that vein of really working on thinking about how could we use healthcare, not just as a way to take care of sick people and work on prevention and all of that, but being in a public health center, really thinking about the linkages between medical care, public health, and society, and trying to improve things on a larger scale as part of a system. So, it kept me going as sort of in this systems thinking mode all the way through, which was really great. So, and I fell in love with Seattle, so I just ended up staying here.
Oh, wow, that's awesome. And then once you graduated from residency, where did your career take you?
So I did a little bit of locums work, and I had kind of intended to do that for about a year and just sort of take a little bit of a break and settle in and then find my next step. But that was not to be. I was doing some temporary work at a community clinic in Seattle, and the sort of clinic site director, the medical director for this particular site in this clinic system, was about to move out of state, and they needed someone to replace her. And so I got recruited for that job. And like many things I've done in my life, I just kind of dove in head first, a little bit unprepared. It's probably the understatement of the century. And so anyway, I became the site director of a community clinic in Seattle that served mainly an African-American and Latino population. And that was a great, very rapid introduction into the inner workings of our healthcare system from the perspective of an FQHC. I knew I didn't, at that time, want to be in fee-for-service private practice, so to speak, or part of a big health system. I'd gotten a little taste of that, and I knew that wasn't really for me. But what I was sorry to find out was that even in the FQHC system, a lot of the same incentives and mechanisms of the fee-for-service system were still very powerfully at work. And so here we were trying to do a lot of great work to serve these communities, but we were still operating under the same incentives of fee-for-service, like, fairly rapid fire visits for very complicated, needy populations that had a lot of excessively complicated lives, with, not a lot of resources, where we were really kind of the main point of contact to try to resolve a lot of issues in their lives. And, a lot of stress over maintaining funding and having to show all the time that we were of value in all these different ways to different funders and all kinds of things. So it was really complicated, very expensive to do care that way, frankly, a lot of overhead. And the more I learned, the more disillusioned I became with the way the system was running. So I did that for about 3.5 years, and was getting increasingly frustrated with the system, and was kind of fishing around at that point for my next step. I wasn't sure exactly what I wanted to do, but I was even kind of feeling like maybe clinical care was not the right thing for me. I wasn't sure if I wanted to do direct care anymore, direct patient care at that point.
Okay. So then what happened next? What did you decide to do?
So at that point, out of the blue, my cousin, who was an internist and had been doing a different model of care for a number of years, called me up. His name is Garrison Bliss. And I had known about his model for a long time, and I had visited him in his clinic. He's in Seattle as well. And I had always thought it was a wonderful model. I'd known about it since I was in med school, but I'd sort of forgotten about it. But he had been doing a monthly fee model outside of insurance for many, many years. He had, been doing fee for service since he trained in the 80s up through probably the late 90s, and had gotten slammed pretty hard by the insurance-based system to the point where it was really not tenable for him anymore. And so he and his partners had switched to a monthly fee system many years ago, and had been very successful, very happy with it. It was a very modest fee, very affordable. I think he charged about $65 per person per month at that time. And he'd gotten to the point where he really wanted to try to do it on a larger scale. And so he called me and said, I want to do an experiment and see if we can do this on a broader scale. I really think this is the solution to what ails the system in terms of primary care. Are you in? And after much back and forth, I finally said, I really feel like I'm not able to make the difference I want to make here. So yeah, I'm in. So that was the birth of Qliance, which became not the first, but sort of the pioneer of the large scale what came to be called the direct primary care model in the United States. And that we've opened our first clinic in spring of 2007 in downtown Seattle, and all took off from there.
Wow, wow, amazing. And so how did Qliance work? What was the leadership team like? And how does work get done at Qliance?
So the model was very simple. We set it up so that people could either pay individually, or an employer could pay for them, or really anybody could pay on their behalf. It didn't really matter. But the concept was that you pay for primary care on a global basis, just a monthly fee, where that fee covered all primary care services. So office visits, phone visits, telehealth visits, texting, messaging, doesn't really matter. Procedures, anything that we used to joke, it's anything we could do with our head or our hands was all included in that monthly fee. And then, some various different materials and things like that could be included as well that were sort of low cost. So we did, services like EKGs or spirometry, so breathing tests, very basic lab tests like pregnancy tests and urinalysis and things like that. Those were included. Anything really inexpensive that's not worth charging for, we just threw that in as part of the monthly fee. Then we scheduled patients for visits, whether they were in person or virtual, for much longer periods of time, that gave the providers, whether they were doctors or nurse practitioners, we used both. So they had plenty of time to really get to know the person, go over their history and whatever issues they had very thoroughly, and really get stuff resolved in one sitting, wherever we could. And then schedule close follow-up in person or by phone or by video, and just to get stuff resolved quickly, timely, and comprehensively. So, for example, new patient visits would be for an hour. So we could sit down, go over every aspect of the patient's health history, really get to know them, really get to understand them, really review their social history, their family history, all the things that help us understand the context of that person, all the things I talked about earlier, that have so much bearing on what puts this person at risk, what determines the kind of choices they make about their health, what determines what they're going to be able and not able to do, so that you don't make the mistake of giving them instructions of things to do that they're just not going to be able to do, or they're not going to, for whatever reason, financial, personal, psychological. It's fine if you give someone instructions of what to do for their health, but if they're not capable of doing that, or, they're nod and say, yes, doctor, and walk out the door, but they're never going to follow your advice because they can't, for some reason that you haven't discovered. And one of the things that Garrison taught me was that patients don't do what we tell them to do, or they keep coming back to us with the same complaint. Things don't resolve. That's our failure, not theirs. We didn't do our job. We didn't find out what's really wrong. We didn't find out what's really bugging them. We didn't find out why they can't comply with what we're saying. Compliant patient. We're a non-effective doctor. So we really took that to heart at Qliance and tried to structure the system so that we could really do our job. When we have enough time and we can really delve into what's going on with the person, we can actually get to the bottom of things. And so we did. We got people in quickly. We got them to understand that we were available. And the minute they have a concern, the minute they have a symptom, they should just contact us. We will help them figure out if it's something serious or not. We will get it addressed. And if they need to go see somebody about it, we will help them get in. We will coordinate things for them. We'll bring them back if they need it. Whatever needs to happen, we will be their quarterback and make sure they get the care they need. And if it's serious, we will for them and get them to understand that it's not something serious and reduce their need for specialty care. A lot of times happens is because in primary care with fee-for-service, where there isn't enough money paid per visit, you have to see more and more people in shorter periods of time in order to, crunch through enough visits to pay the bills. That actually drives up the cost of care because you have to have more people supporting the doctor to get them through the visits faster. The doctor can't do as much, so they have to refer more. They have to order more studies because they can't do good clinical medicine just using their brains to figure out what's going on by asking a lot of questions. It's good detective work most of the time. And then patients get nervous because they don't feel like the doctor really had time to listen to them and figure stuff out. So they end up demanding more tests. So you get a situation where people want more tests and they want to see a specialist and they want to do all these things. It's not because they actually want to do all those things. It's because they don't trust that someone really got to the bottom of what's going on. So we were able to reverse that whole thing and help people understand that most of the time, if you really ask and do a thorough evaluation, a lot of times it's something that's known or with some sort of minor intervention or just low risk type of treatment, or that you can watch and wait for a little while and see what happens, and that we will be there for them and help them out along the way. So that was kind of the approach to the whole thing. And, we did staff. It was very simple. We had simple operations. We had, wasn't super high tech. We didn't get caught up in all that. Really sort of kind of get back down to the basics, but just making ourselves really available to people. And they absolutely loved it. They couldn't believe that this kind of care was available and that it was really pretty inexpensive. Asking us, like, how can you do this for this price? Originally it was like, I don't know, I think we charged somewhere between $40 and $80 a month per person, depending on their age, and people couldn't believe it. But it's just how little concept people had of what the real cost should be in healthcare. And they didn't understand that over the course of a year across a population, that actually was great money to take care of a population of people, and we could totally make it work. And that across a system, if we were allowed to do our job and actually talk to these for long enough and really take care of them, their need for the downstream care with specialists and stuff really went down. And that the costs in the system would start to go down dramatically. And that's what we found out later.
So Dr. Bliss, can you give us an idea, give the listeners an idea of what was the size and scope of Qliance?
So we were in business from 2007 to 2017, so 10 years. And over that time, we started out from, literally one or two patients, mostly individuals who signed up. And gradually over the course of those 10 years, we peaked at about 45,000 patients was our largest number. And that was sort of I think that was in 2015, a year after the implementation of the ACA. And at our peak, we had grown into taking contracts with very large employers like Expedia and Comcast. We had, contracts with some union trust funds like the Seattle firefighters and other folks like that. We also had a very large program with a Medicaid managed care company in Washington State, who also had a product on the exchange in Washington, the Health Benefits Exchange. So we were doing individual care for employer plans, union plans, and Medicaid, as well as Health Benefits Exchange plans. So it got very large, and it actually grew very fast with the Affordable Care Act. So we were taking care of a very large number of people. And we had also at our peak we had 7 locations in the Puget Sound area. And I think we had also at our peak about 20 medical providers and a total of 130 employees.
And can you give the listeners some idea? I've seen the presentations that you offered on the clinical and financial outcomes, but could you give the listener kind of an overview of that?
Sure. So At different times, we did different analyses of the cost outcomes of the population. It's difficult to do. It was difficult to do for a long time because getting access to the total cost data of a population is hard to do unless you're really working with a payer. And because we were outside of the payer system and working with a disparate group of people, we didn't necessarily have access to that. And it was hard to get payers to cooperate in any way to give us that information because, of course, I shouldn't say of course, but they did see us as a threat. They didn't like the fact that we were taking control over some aspect of the care outside of the purview of the insurance company. Any claims that don't happen within their system are claims that are a black box to them. And this was something that they were very uncomfortable about. And they fought us in the state legislature and with the insurance commissioner all along the way for the entire time we were in existence. That said, when we started working with larger employers, we were able to then get some of the data because the employers controlled that data. They basically used the insurance companies as their third-party administrators, not as a true insurer. And they had the right to that data through their consultants that managed that. So we finally had an opportunity, starting with those, to see some total data. Prior to that, I was able to start doing some estimates based on the documentation we had of what happened to our patients. So even before that, I was able to start doing some estimates on hospitalization days and surgeries and all of that. And we were very careful about getting all the information back about our patients and what happened. And we really did know what was going on with them. So already even before that, we knew that our rates of hospitalizations and surgeries for non-essential surgeries, things that could generally be avoided, for advanced radiology studies and things like that were well below the expected for our populations. But when we started to look at our employer customer data, we saw that was also the case. And so we saw on a, it varied by population, but we saw consistently significantly decreased rates of hospitalization days, significantly decreased rates of specialty utilization, significantly decreased rates of advanced radiology studies. In some cases, we saw increased rates of prescription utilization. Now, that can be a good or a bad thing. Sometimes it means that people are actually filling and using necessary medication. So it all depends on the medications you're talking about. So we also looked at things like what are our generic prescribing rates, and those were always very high. So typically much better than the average for different prescribing groups that were looked at. The other thing too is that we got things like you have to look at what they count as specialty. So when we drilled down sometimes into the specialty utilization, we found that they were counting things like physical therapy. Well, physical therapy, as opposed to orthopedic surgery, is a way better specialty service to use when you're talking about rehabilitating people and keeping them healthy, right? I mean, it's better if you have an orthopedic injury to be getting someone rehabbed through physical therapy than having them go in for a surgery. So there was all kinds of interesting things we found like that. We were very heavy utilizers of rehabilitative services like physical therapy, and convincing people to do that and do it consistently rather than sending them straight to an orthopedist when they have a musculoskeletal issue. Then when we did the Medicaid program, we finally had access to very complete data. And we also had access to cost data. And that's where we started to really see some dramatic results. And it varied by population. Of course, in Medicaid, you've got folks who are permanently disabled. You've got folks who are, moms and babies, so to speak. It's a very diverse population. But again, the same pattern: big reductions in hospital days, huge reductions in radiology utilization, huge. And in fact, to the point where it was so compared to their average utilization that it was, I didn't even believe the data. I told them to please go back and rerun it because I thought they must have been missing something, but it turned out that it was true. And with no difference in outcomes. And again, it comes back to what I was saying, that we had the time to properly evaluate people, ask enough questions, examine them, and follow up, so that we didn't need to order a CT scan for everything. We didn't need to order MRIs for everything. We could actually take care of people, use good clinical judgment, and get them doing better, and therefore heavily reduce our dependence on all these testing modalities that oftentimes are really not necessary and don't add a lot of value. So it was just consistent across the board. And we were able to reduce the overall cost of care for our Medicaid populations very significantly, well below the expected cost on a consistent basis for the Medicaid plan. And some of our, the contract we were on with them rewarded us to, in a shared savings arrangement, so that we got to share some of that savings if we did really well. And we consistently got a savings bonus from the plan for doing that. So that tells you we obviously saved money, because they wouldn't have shared that with us if we hadn't done so. And the fact that we got bonuses consistently throughout the years that we worked with them, that tells you the whole story.
So you Qliance became a hero for the direct primary care movement, the prospective payment model, just really showing what was possible, and which is why we're doing this Bright Spot interview with you now. I'm wondering if you'd like to comment on what were you most proud of with Qliance, becoming really a national leader? What do you, the CEO of that organization, what were you most proud of?
Gosh, great question. I think that, this may sound a little corny, but as a doctor, I feel most proud of the fact that we were able to personally touch so many people's lives and make them feel that they mattered. I remember in medical school thinking how much I despised the inequality and injustice of our healthcare system, and so many other things about our society. To have the U.S. be such a wealthy, powerful country that has such maldistribution of resources and so much injustice, and to have never fully overcome that in our history since the inception of this country. And it really bothered me to be in a very, UC San Diego is a very wealthy area, but with tons of disparities. The medical school had a ton of resources, but we saw disparities throughout the system. I hated that. And I hated the fact that, within the system itself, the places where people got care, you could tell they were all being segregated. And it was just, it really bothered me. And I remember saying in med school, I want someday to provide healthcare in a place where everybody from all walks of life can come to the same place and feel like they matter, that they are respected, and they are treated with dignity and respect. And they can be rich or poor, but they all come to the same place, and they all sit down together and they get healthcare in the same place. And I'll never forget, we'd been in business for, I guess, about a year, or I don't know, a couple of years, maybe, I can't remember when it was, but I walked out into the reception area, and we didn't have a lot of people sitting in the waiting room because people didn't have to wait because we didn't have that kind of a business. And, but there were a few people sitting out there, and I knew who they were. And I knew that a couple of them were very wealthy people, and a couple of them were very poor on Medicaid, and a couple of people were, somewhere in between. And this being Seattle, people are very casual, so you probably wouldn't know from how people dressed. And I knew from working in a community clinic that what a lot of people of means don't understand is that poor people oftentimes go out of their way to really dress nice when they go to doctor's appointments and things like that, because they're so worried about being treated badly or dismissed. And so they make an extra effort to look really nice as best as they can. because they're so used to being mistreated. So oftentimes people don't realize who they're sitting next to. And then, people of means oftentimes dress incredibly, casually.
Right.
Anyway, so I stepped out to just kind of talk to the front desk for a moment. And I looked around and I said, oh my God, we've done it. We've achieved my dream. It's the place. And that's when I knew that to me was success. That was what I felt like my personal dream had been, was to create a place where everybody could come and feel that they were being treated with dignity and respect. So for me, that was what personally the greatest success of Qliance was, is that we were able to show you can take care of everybody, literally. Anybody who walks this planet could come to a place like that. And it was a nice clinic, wasn't super fancy, but it was nice and it was clean and it was pretty. And people there, I don't care who you were, you got greeted nicely, you were welcomed, you were made to feel like you were important, and you got great care. And when you walked out of there, you felt like, wow, that was great. And everybody told us that. And our Medicaid patients would like break down in tears and say, like, I have never been treated this way before in my life. Not in healthcare, but not like never anywhere. And it made me sad that that's the kind of society we live in, but it made me feel so gratified that we had created a space where those folks felt like they mattered. So to me, that was the greatest success. And I feel like and those people's health started to just shoot up. They got so much better. And not that we could, make everybody's health perfect, but I saw such huge improvements in their lives and in their health. And it was so rewarding for all of us to see that, that I feel like I wish we could have kept going, but it showed me that it's possible. And I feel like if we could do that, and if we could get that going on a larger scale, that's what I feel was the greatest success of Qliance, is we showed that it's possible. And that's possible for every single person in this country, that it is not that hard. It just takes the social and political will to make it happen in this country.
So I'm going to fast forward now beyond the story of what undermined Qliance and led to its closing. But for the listener, you're, Dr. Bliss, an innovator who creates opportunities and then builds to take care of people in the way you just described. Can you give us an update on what you're doing now?
Sure. So Qliance closed its doors in spring of 2017. And I, by necessity and also because I wanted to, struck out on my own as a solo practitioner. I couldn't imagine going back to fee-for-service medicine. I hadn't done it for 10 years at that point. And it was like direct primary care or die at that point for me. I just couldn't imagine going back to a system that would not allow me to take the kind of care of my patients that I had learned how to do. It had just been, it was too far past that point. So, and also I had a lot of patients who had entrusted me with their care for a long time, and I needed to be able to continue to take care of them. So I opened a solo practice called Equinox Primary Care, and a number of my patients, pretty much all of my patients, came over with me at that point. And, as Qliance dismantled and people went their separate ways, my patients and some other patients came with me. I continued the direct primary care model, so just very simple monthly fee. I don't take insurance, just like we didn't with Qliance, so I don't bill anything fee for service. Extremely simple. I have one medical assistant who works with me about 80% time. I literally stood it all up in no time at all. I have, my practice is probably about 2/3 full now. And again, it's a wide variety of people from all walks of life, all ages, babies to people who are at the end of their lives. And I do comprehensive outpatient primary care. I have a little office in downtown Seattle, and I do, some in-person care, a lot of telemedicine, It always has been that way, and what we learned at Qliance has applied here too, which is that in general, once you get to know somebody, a lot of the care shifts to telemedicine. It used to be that a lot of it was by phone. What I found with the COVID crisis is that I'm using video a lot more because it's hard to, we all feel kind of out of touch. And so being able to see somebody's face, it has meant a lot more than it used to. So I've been finding myself rely on that a little bit more. But even prior to this, I think my schedule was easily 50% non-face-to-face visits or contacts, either phone or texting or patient portal messages or something like that. So that's been the case from the beginning. My patients have anything from very uncomplicated health, and they just want to stay healthy and have someone that they can tap into when they have a question, to people who have extremely complicated health profiles and need lots and lots of management. So it's very interesting, never a dull moment, constantly learning. I absolutely love it, and have been really enjoying the shift from having grown to being the CEO of a fairly large company with a lot of stressors to being just running a solo practice and getting to focus in on the joys of direct patient care alone.
So what's happening with the COVID epidemic? How does that influence your development and your operations?
So unlike a lot of practices out there, or the majority of practices that have been struggling to switch over to telemedicine, it was literally overnight for me. We already doing telemedicine is a big part of the practice, and not having to worry about getting paid whether I was seeing people in the office or not. It was really it didn't require any thought whatsoever to just reschedule people and say, hey, let's not do anything in person until further notice. Unless absolutely necessary, I will call you, I will set you up for a video visit. And my assistant and I contacted everybody and just reshuffled the schedule overnight. What we've done is my patients are able to schedule themselves. And then if they need assistance, we can schedule them. So we just switched the online scheduler to only phone and video visits. And if they need an in-person visit, we screen them first before we decide whether we're going to bring them in. And then after about a week, I sent my assistant home, and I went home, and we just have been working from home mostly, and I just go in to see people as needed. So it was literally like flipping a switch, made it so easy to flip over. And because I have a monthly membership practice, my revenue didn't take a hit, and I didn't have to worry about what I was going to do tomorrow or whether I was going to be able to keep her employed. And I was able to reassure her almost immediately, don't worry, you have a job. We're going to be okay. Even if a bunch of our patients lose their jobs, I'm just going to comp them their care. We won't worry about that. I figured it out. This is how much, I can afford to give away this much care before we have to worry. And even then, here's my plan B, and, talk to the landlord, et cetera, et cetera. So I was able to reassure her so she and her family didn't have to worry. I was able to make some plans. I was able to budget for what I could do in terms of patient care so I could reassure my patients that they didn't have to worry. It was so nice to be able to immediately say, within 2 days, I had a whole plan, because I had control of my revenue and I had control of my delivery system, because it made sense in a situation like this. And I could just flip everything into disaster mode, basically. So that's what we did. And then I was able to immediately be there for my patients in a very efficient way that basically a bomb could have fallen on my clinic and blown it all up, and I would have still been completely fine. No problem. So, and I, by that time, had become so comfortable with telehealth that I didn't feel like I needed to develop a whole bunch of new skills. I already was very comfortable with assessing patients over the phone and by video, and having them pass me information back and forth by photos, by home blood pressure and other assessments, by monitoring things over the course of several days and feeding me information. I had gotten very comfortable with that and understood what you can watch, what you can't watch. When do I have to send them in to get labs? When do I need to do this? When do I need to do that? It's something that I've realized is a skill set that you grow over time, just like anything else. When you first do it, you feel a little bit nervous about it because you're so trained, you have to see the patient and lay eyes on them in person and put your hands on them. But you start to realize there's a lot you can do without actually having the patient in front of you, including things like I just did a video visit with a mom and her child yesterday. And I was trying to figure out what's going on, whether this is sinus or ears or reflux or something like that. And I realized I could have the mom tug on her ears for me. Is this an ear infection of the ear canal? If she tugs on her ears for me and the kid isn't feeling any pain, that tells me something. If she taps on her face over her sinuses and the kid isn't feeling any pain, that tells me something. If she presses on her belly for me and the kid doesn't flinch, that tells me something. So someone can actually help you even with physical exam findings and give you a good idea of how bad the person might be. Just looking at them on a video and watching them breathe. I've been doing that with a lot of patients. Watching them breathe in and out, you can tell a lot about how comfortable they are. You don't necessarily have to listen to their lungs. So that's the kind of thing that if you do this for a while, you get a lot more comfortable. And if you know those patients, you know how much you can rely on them to use good judgment about their own symptoms. And if you're not sure about, you can just check in with them every day and make sure they're okay. Anyway, all of that together, I have found that it's been really easy to get patients reassured, healthy, safe, out of trouble, et cetera, et cetera. And throughout last month, I've only had 2 people have to go in for anything out of about 400 people. And those were for non-COVID related issues. They were for other things that really had to be addressed. Otherwise, we've been able to keep everybody at home and I've been able to monitor everybody and all that kind of thing. I'll pause there for a second, then I can talk more about the telemedicine potential, but let me stop for a second and see if you had any questions about that.
Allie, any questions?
Not at the moment. No, I'm fascinated by what you're saying, Dr. Bliss.
So I'll talk a little bit then about the potential for telemedicine, because one of the things that I did, I was sitting around when this whole thing hit thinking, God, I wish I could do something. I'm really worried about my colleagues in the hospitals, but I'm not part of the hospital systems anymore. I'm an independent doc. I'm not credentialed at the hospitals. I don't serve in the hospitals. I'm really worried about what's going to happen if we get hit with a big onslaught of patients, and I want to be of service. So I signed up for the volunteer service corps and all that kind of thing. And, was sort of sitting, biting my nails, wondering what was going to happen. And then I thought, well, what can I do? What can I do? What can I do? And then I started hearing about all these patients who couldn't get in to see their doctors or didn't want to go in because they were nervous about getting infected or couldn't get a hold of their doctors or didn't have a doctor. And it suddenly dawned on me, while there was all this discussion about telemedicine and getting paid for telemedicine and getting set up for telemedicine and on and on and on. And I thought, well, I have some capacity in my practice. I'm not busy every second of the day. I could offer a telemedicine membership that, as they were relaxing the requirements across state lines and all that kind of thing, I thought, well, I could just offer this to anybody. And so I decided to set up a telemedicine only membership for anybody who wanted it. For the duration, I decided to just make it available for 6 months and decide after that what I wanted to do with it. So I set up a telemedicine only membership. I decided to just set up a charge of $25 a month, which would sort of help defray my costs, but be low enough that hopefully it wouldn't be a barrier for people. And I, of course, would negotiate it with people if they couldn't afford that. I just, I was throwing a spitball against the wall. It wasn't intended to be something to make money off of. It's probably lower than my actual costs, but I just didn't want it to be a huge barrier. And the idea would be that people could have unlimited access to me via phone, video, texting, etc. And I would be their primary care doc or a supplemental primary care doc for the duration of this crisis while people can't get good access to care. And it wouldn't be just for COVID-related stuff. It would be for any primary care issue. So that while the healthcare system is in chaos, they don't postpone or avoid getting care for things that are important. And the other thing that inspired this was that there were telemedicine options for things like, can I qualify to get a COVID test? And I had a patient call because we didn't have a lot of testing available here. We still don't. And one of them, the family sat on the phone for 2.5 hours, finally got through, and they literally had less than 2 minutes on the phone with the doctor who screened them appropriately. And turned out he didn't qualify to get the test. And then that was it. There was no room or time for any other questions because they had to get through all the other calls. And that kind of, for me, culminated the whole thing where it was like, well, people have other questions. What about family members? What about this? What about that? People are just going to have a whole lot of health questions. Who are they going to call? There's nothing else available right now, and nobody has time. So that's when I started to remember when we were running Qliance, what we were starting to try to do when the company had to close down, which was we had started to think about a clinic without walls and where the healthcare system really should go. And I thought, well, now is the time we really should sort of revisit this whole idea. So the idea with that was that there should no longer be this idea that all healthcare has to start with a one-on-one sit-down visit with a doctor. That you shouldn't have to establish a primary care relationship. Why do we have to have a face-to-face visit with a doctor or a nurse practitioner, which is a very difficult to obtain, costly, time-consuming thing to, quote, establish care in order to get access to care? Why is that the gate you have to get through? Because what happens then is people avoid establishing care with somebody until they have a need, and then they have to wait, and then they have to go to an urgent care or an ER, have an encounter with somebody they don't know. It's in an expensive setting. They've put it off until the last possible minute, and that's the worst time to get a problem taken care of. So we said, why not have the channel set up beforehand in the lowest barrier possible way so that people feel that they have some sort of primary care relationship and it's there, so that when they have a need, they don't wait so long. They just tap into it, and then they go from there. So what we started offering with Qliance in the last couple of years of its existence was a program we called Access to Active, and we got most of our employer customers flipped over to this program, where we said to them, just sign up all of your employees. Put them all in the access mode, which is essentially a telehealth option, where they all have access to us for telehealth. They don't have to switch their doctors. If they have somebody else they want to see, that's fine. But they also have us for telehealth. And what we will do is reach out to them and say, hey, we're here. If you want, fill out this health history questionnaire. We'll put it in our system. And then if you ever need us, you just contact us. We'll know a little bit about you, just very basic health history like allergies, medications, and what your health problems are. Nothing more than that, so it's not invasive. And that way, when you call us for a problem, we'll know who you are, we'll know a little bit about you, and it'll be really easy to get you taken care of. And we already had a 24/7 telehealth service set up, and we had 7 clinics and a whole bunch of providers available, so it was easy for us to handle that. And then people stayed as access members up to the point that they decided they wanted to make us their primary care provider. And then they would switch over to being a full primary care member, and that's when the fee would go up to the employer. And so the idea was that we would make it really, really easy for people to access primary care, but they didn't have to have a sit-down appointment with us in order to start that relationship. So using that idea, what I did with my telehealth model is I said, you can join as a telehealth member. It's a lower fee. I'll do an onboarding visit with you if you're willing to do that. And I just got on video with these folks. I had them fill out a health history form. I went through the whole history with them. And if they had a health question or problem or anything, we talked about that. And if they didn't, we just said, well, nice to meet you. If you have any questions or issues, I'm here. Here's how you contact me. We're good to go. And you can continue this membership as long as you want. I'm doing this for at least 6 months. If I am not going to continue the program at 6 months, I'll let you know. Otherwise, you're welcome to stay on as long as you want. And if you want to change and become a full member where you can come into the office, you're welcome to convert at any time. So I set that all up, and I sent an email out to all my patients, and I said, hey, try to help people who don't really have good access to a doctor right now. I'm setting up this membership. Feel free to send this out to anybody you know who might be able to make use of it. And immediately, a bunch of my patients said, hey, this is great. I'm going to sign up family members, friends, people I know, or I'm going to send it to them. And a lot of them actually sponsored friends and family who they were concerned about, who were either in isolated areas without good access, or who didn't have doctors, or who were parts of systems where they didn't think they had good access to their existing doctors, or whatever the case may be. And so I probably got about 20 telehealth patients signed up. And I'd say about half of those have actually contacted me or agreed to, we reached out to all of them, but about half of them have actually connected with me. And we've had a telehealth visit either just to onboard them or to deal with a specific problem. Some of them have been COVID related. Some of them have been completely unrelated. Some of them have wanted a second opinion on what their own doctors are telling them, which is kind of interesting. So it's been all over the board, and it's really made me stop and think about, we really need to do this. This could be a much more cost-effective, comprehensive way to get people good primary care in this country without having to build a whole bunch more clinics and worry about and much better utilize our existing primary care workforce while we work on building a bigger primary care workforce, to unclog our clinics and bring down the walls of the clinics, rather than everyone having to have this in-person, established care visit. We could have an established care visit with everybody via telehealth, get everyone up to speed, and then determine by meeting all these people virtually who actually needs to be getting into the clinics for care, prioritize those people, and then work our way through the population. So we could actually make the clinics into population health managers, sorting through people and prioritizing who needs to come in, kind of like they're doing right now with the COVID crisis, right? This is kind of what clinics are starting to do now. They're doing this by necessity. They're having to filter through people and say, you sound really sick, you need to come in, here's how we want you to come in, I want you to stop here and do this and do this and do this. You sound like you're fine, you stay home. We're going to call you tomorrow and check on you and make sure you're okay. For now, stay home and do this and this and this. You sound fine, but you're really worried. We know you're really worried. Okay, fine, you can come in, etc. So it's a much more orderly utilization of clinic resources and medical resources than we've ever seen. And it makes sense to do it that way. So we've been sort of forced into an orderly utilization of resources that we have refused to do until recently. All I'm saying is that the monthly fee model facilitates that. It's not magic. It's just a business model that has allowed a lot better organization, utilization of resources and care to do what we're now being forced to do as a society. And it creates, and the one other thing I'll say about this too is that we've had telehealth for a long time. The problem is that US telehealth services like Teladoc and American Well or whatever, I'm not picking on them, I'm just naming companies so people know what I'm talking about. Those services are not what I'm talking about, because when you call telehealth or any of those other programs, you get a random provider. You call up, you get connected with whoever's available, you tell them your problem, and they give you advice. You say goodbye, that's it. You're never going to connect with that same person again. There's no continuity health record. There's nothing that connects back to your overall health over time. There's nothing that connects you back necessarily to your primary health care provider. This model is primary care telehealth, where you are connecting with your primary care provider, over time. And if you do this on a larger scale and it's one system, then even if you do connect with somebody else because your primary care provider is not available, that other person is connected with your primary care provider and is going to communicate back to them. Just like when you talk to your practice's doctor on call, who says, okay, I'm going to tell your doctor on Monday about this and we'll get back to you. So you feel like it's the same person or their colleagues taking care of you. You're not just talking to a whole bunch of random people and things are getting missed because it's all spread out across time and space. So this idea is you take telehealth and you bring it to the primary care level and it's managed at the primary care level so that people get true comprehensive health care.
So Dr. Bliss, I just want to say I think this is brilliant. We might rename it millennial care, because what you're describing is the kind of thing that I've heard many millennials say they don't want to engage in a deep relationship. They don't want to go in heavy, so to speak. They have a problem, they have an issue that they want to talk with somebody about. And I think if this allows them to build a long-term relationship with a primary care practitioner or a primary care practice, that trains them and guides them in the right direction. So if they do develop something more substantive, that they have a relationship and they're not just lost in the storm, so to speak. So I'm going to bring things to close because we are about to run out of recording time here with the platform that I'm using. And I will just ask if either you or Allie has any final comments.
I would just say that, as I think so many people are saying right now, if you look around the world at any great social change moments, any great systems that have been brought into being, any great social changes that are brought into being, they never happen just because people say, this is a great idea, we should do it. They only happen at times of great upheaval. Some things have to break in order for new things to come into being. So I think, the history of the NHS is a great example of this. I think that that's potentially what we're looking at here. And while this is a terrible situation to experience, i.e. a global pandemic, it is throwing into very great clarity the shortcomings of the American healthcare system, right, and potentially giving us the opportunity we need to make some tremendous changes. So I really hope that the American public and political leadership will recognize this opportunity and really push for some fundamental changes that will make it better for everybody.
I'm with you. Allie?
I completely agree. And Erica, your outlook on medicine and the healthcare system that began as a medical student, I completely identify with. And I want to thank you for taking your career to show what's possible. So thank you.
Well, thank you. And I'm so glad you're joining the ranks.
Yeah, thanks.